Thank you so much. So, for our very last session of the day, we would like to present some kind of specific California landscape information. We do talk about how everything is really specific to the state, right? And in this particular challenge, our goal is to get you all connected with each other and all of the other players that you may come across throughout this process. It's really great for networking. It's really great for that was a perfect example of like, oh, here's another opportunity you may not have heard of. Um, but the end goal, right, is to get you a pilot with a safety net focused organization in California. So we really want you to hear from the people that are specifically there, which is Janet and our expert today, Dr. Dennis Hsieh, which I will let Janet introduce and we'll just get started. And from what I understand, Q&A, again, very welcomed. Very much want to, especially since we have a small group, connect individually, and really just so again, raise your hand, throw something in the chat at any time, and we'll kind of try to keep things moving. So, Janet, back to you.
Yeah, yeah. Won't have much to say. I will let Dennis introduce himself, but just a few words. Dennis has been like one of our most incredible subject matter experts. Like he shares gems all the time. Like we had a conversation on Friday. I was like, I didn't even know that. And so I'm super excited that he's been able to join us today. Um, Again, going back to what Darby said, please, please, please feel free to ask any questions that you have. It is a safe space. No question is a dumb question. I mean, the whole purpose is to make sure that you get all of your questions answered. And we'll keep watch of the queue, ask as many questions as possible. And I'm going to kick it over to Dennis to do some intros, and then we'll jump into some Q&A. Hey, Dennis.
Good afternoon. How's everybody doing?
Good.
Good. Nice. Well, I know you guys have had a long day, so hopefully I'll keep you guys awake. So I'm Dennis Hsieh. I'm the Chief Medical Officer here at the Central California Alliance for Health. We're a Medicaid plan. We're a county organized health plan, which means we are basically a government entity that's not part of the county. And we do pretty much all Medicaid in our 5 counties, which are Santa Cruz, Monterey, Merced, San Benito, and Mariposa. So we pretty much go across a whole stretch of Central California. And before this, I was at Contra Costa Health Plan, which was also a county plan covering the county of Contra Costa, as the name might suggest. So, I think happy to talk about whatever. I think based on what I'm hearing, I can give you a little bit about what's going on in California right now in the Medicaid space, and a little bit about my perspective of sort of being someone who gets a lot of emails, gets pitched a lot, and sort of what I'm looking for. So I think, California is, despite budget cuts, is undergoing a ambitious journey in Medi-Cal. It's called CalAIM. Many of you probably know about CalAIM, and CalAIM is basically the name right now for all changes in Medi-Cal in California or Medicaid. And there are a lot of different things, right? So there's things in behavioral health in terms of making sure individuals with mental health concerns get to services more seamlessly, not getting turned away because, oh, you have to go to that place instead of here, things along those lines. There's a lot of work around social determinants of health, especially in the space of enhanced care management, which is case management for the highest risk individuals, as well as community supports, which is basically paying for things like temporary housing, food, revising your house so you can stay in your house if you use a wheelchair and you weren't using a wheelchair before, things like that. And then a lot of other changes around supporting, sort of non-traditional providers. And what I mean by that, like doulas, right? Sort of paying for doulas in California. dyadic care, paying for basically mental health and physical health for parent and child to be done in the same visit, so you don't have to go to 4 places to get that done. So lots of interesting things going on. And I think, I think that leads me to my first piece of advice, right? A lot going on. I think, I recently, a couple days ago, just talked to a provider, and had I not known about them from Janet, I would have ignored their email, because their email was like, oh, we do maternal and child health. I'm like, great. Everybody does maternal and child health these days. Not really interested. But Janet told me they were doing enhanced care management for pregnant patients, and they also do doulas. And I'm like, oh, well, that's what I'm interested in building out right now. Right. That's still maternal and child health, but like, I don't have the time to go dig in and look at what you're doing, right? Like, you have to put doula enhanced care management in the first line of your email. Otherwise, I'm not going to pay attention. Right. So I think what I mean by that is, like, you all know what you're doing, you know what you're interested in. But when you're pitching, you can't just generically pitch, right? You have to understand, what are the funding sources, what are the requirements, what are the providers doing, because right now it's like drinking from a fire hose. So if you're going to tell me you're going to turn the fire hose a little bigger for me, not interested, right? If you're telling me you can help me drink from the fire hose, very interested, right? So I think it's really that kind of framing that's really important. So I think that's a couple of quick minutes on, in general, what's going on in California. Sort of a couple of the key ways to engage, right, is messaging, because yes, we all have grant programs, but most of our grant programs are not directed towards startups, right? Our grant programs are directed towards our providers, our community, and what they're doing. So, that does bring me to a second point, which is like, another way to get involved with the health plan is to partner with our providers, right? Because I have seen those fun things, like, our providers, like, oh, my patient scheduling system sucks. I heard about this really great scheduling system. I'm working with them. I need some money to get it up and running. We'll pay for that, right? But that's really because the provider is pitching us, because you pitched them, they bought in, they want to work with you, right? The plans themselves don't necessarily have a lot of bandwidth right now to do new and interesting things, unless it fits into a box that they're already have to do or are doing, if that makes sense. So I'll start off with that. I don't want to keep on blabbing at you. I'm sure you guys have questions. And then I'm happy to keep on talking if no one has questions, but I'll start off with that, and curious to hear what people are interested in talking more about.
Hi, Dennis. My name is Decca, and I'm actually one of the providers for CCAH and also Contra Costa. So I'm so happy to meet you. My question,
Nice to
since I
see you.
have you on the call, is there for the IPP funding, is there a maximum that one can apply for?
Great question. So just for everybody, so IPP is it's the incentive payment
Incentive
program,
payment program.
which is basically specific funding that's been made available from the state to the health plans to then give out to providers. And this is usually specifically around providers doing either enhanced care management or community supports to build out capacity. So I think the question is, it depends. Every plan has operationalized that differently. Every plan has a limited amount they've gotten from the state. But in terms of how much of that they're giving out, and sort of how much of a limit there is per provider, it really depends on what the plan has decided. For us, I think if you're doing new things, like, okay, you've started off doing enhanced care management, but now you're growing, there's capital costs, that's where we would consider a second grant. But I think every plan has a different policy on that.
Okay, thank you.
No problem.
Hello, Dennis. My name's Brian Young. I'm founder and CEO of Apollo Technologies. Wanted to get your thoughts on I've asked pretty much every speaker, but what are your thoughts on the challenges Medi-Cal will experience with the expansion of the coverage to undocumented immigrants, and more specifically, what is your organization doing to prepare for that influx of newer patients and the
I mean,
challenges that you guys are facing?
yeah, I mean, I think in general, right? I think the challenge for individuals who, um, the new population, right, the 21 to, or is, yeah, the 21 to 64 age group,
Yeah.
right, who previously were not eligible for Medi-Cal in California, but now are because of our expansion to everybody else was who didn't have documentation status was covered earlier. I think the biggest challenge is just sort of fear and lack of knowledge, right? In terms of people are still worried if they sign up, they'll get deported. It'll affect their green card status, right? That somehow other things will happen to them, right? But I think it's either that fear of deportation or fear that it'll affect their ability to get a green card or to become a citizen at some point are two of the biggest challenges, even though neither of those are true. And I think, in terms of signing up for Medi-Cal, we do have some education on that, right? And I think this is sort of really from our perspective, because how it works, right? The state signs people up. We do not control eligibility as a health plan. The state, local in California is done by county. So the county, like social services or health services or public health department, every county is different. Whoever runs Medi-Cal eligibility really has that job of signing people up. And then once they're signed up, depending on which county they're in, for us, because we're the only Medi-Cal plan, they eventually get assigned to us, right? In counties that have more than one plan, they get assigned maybe to the other plan, one plan or the other plan. So I think, what we've done is some very basic public education, right? But then I know traditionally what has happened is there's sort of some more targeted, focused materials available, usually from advocacy groups like immigrants' rights groups and others who are really sort of targeting that public charge fear of like affecting immigration status or affecting public, or causing deportation, along those lines of the sign up piece. And sorry, give me the second part of your question.
Yeah, so the challenge, like the challenges to that influx of patients that your organization will be receiving,
Mhm.
um, what are the challenges that you're anticipating, and like what are the solutions that you guys are already starting to ramp up to?
So, I mean, to be perfectly honest, we're not getting a huge number. We're getting about like 30 to 40,000, maybe a little more. And I think sort of your question is a good one in that it does point to some of the inherent challenges of working in Medi-Cal, right? So I'll answer from that perspective, right? Because I work in the Central Valley and the Central Coast. So, you know, people and providers are not necessarily looking to come to Merced, right? Or San Benito or Mariposa counties. So I already have these challenges and are addressing them. Having more people doesn't change what I'm doing for them. But I think some of the key challenges are both, if any of you are working on this, would love to hear more about it too offline, right? Like not sufficient number of providers in the community, both primary care and specialty care, right? Because it's geographically underserved. There's some issues around transportation in the more rural areas, right? Just lack of transportation providers. And then I think um there's also sort of a question of like quality of care, but I think at this point that's not even a question I can really get to, right? Because if I don't have a provider or I have one provider, unless they're like going to jail, for the most part, it's better to have a provider than not to have a provider. So like I'm not even really thinking quote unquote about quality, right? Because I'm just thinking about access, right? Telehealth can address a little bit of that, but there's a lot of stuff you can't do by telehealth. And there's also sort of literacy, connectivity, and challenges around telehealth as well.
Yeah, yeah. Our company is actually focused on capacity challenges and everything. So it was definitely we would like to connect. I'm more than happy, like, love to chat with you at some time to learn a
Yeah,
bit more about the challenges. Uh, is there a good email address or? Oh,
yeah, I'll
perfect.
throw it in
Thank you.
chat.
Okay, awesome. Thank you. Appreciate it.
Cool. Catherine?
Hi, Kathy Kim from Activate. This is kind of a follow-on question to what Ryan was talking about. So we have a platform that has done care coordination, supporting capacity building in the community health centers to incorporate remote patient monitoring, sort of the data into streamlined care coordination pathways, integrating data into the EHR, and training the staff on how to build all of this into their workflows. My question is about sort of demonstrating enough value to the point where a health plan would pay attention. So we've done it on a pilot basis, a couple hundred patients. And we've shown that providers can actually increase the capacity of patients that they see without adding any hours, and without adding additional staff. But people say to us, well, you've only done it with 400 patients. You've only done it with 4 sites. So how much do you have to do to get a health plan to say, yeah, we'd like to take a look at that?
I think I would reverse the question, right? Because that's, I mean, if I'm working with my clinics to streamline their workflow, then I'm interested, right? But that's a secondary consideration for me, right? Because your real customer is the clinic, right? Because I'm paying the clinic to see patients, I'm paying the clinic to produce better quality, right? I'm not micromanaging how they schedule appointments, nor do they want me to in most cases, right? So I think what you're doing is super valuable. And, sort of from my perspective, the pitch would be to the clinics, right? Hey, I know you're being asked to see more patients. I know capacity is a problem for you. Can I work with you to increase your capacity without increasing any more hours or any more providers, right? I think they'd all be interested because they could bill me for those extra patients, right? They're incentivized to do that already. They're interested. It's just sort of, can you get their attention to help them do that?
Yeah, and show that you have enough value so that they're willing to pay for the technology to do it. Right?
Yeah, and I mean, I think that's just a math problem for them, right? If you're telling them I can increase you by 400 patients, they're going to look at their cost for 400 patients, look at their margin for 400 patients, and if their margin, what you're charging to do that is less than their margin for 400 patients and the staff time it takes, right? Then the math problem works. If the math problem doesn't work, then they're not going to pay for it.
Thank you.
Yeah, you should talk to our practices.
What do you want to?
I was going to say you should talk to our practices in Merced. I think they
We have one of your practices in Merced.
Yeah, they would all benefit from some of your assistance.
Yeah, we're in Livingston right now. That's where we've done a big demonstration.
Yeah, you should talk to Golden Valley and MFA and all the rest of them. If you need an introduction, let me know. I'm happy to send you their way.
Wonderful, thank you.
Of course.
Anybody want to jump in for the next question?
I got tons of questions, but I don't want to step on anybody's. Okay, well, if no one wants to go, so
Oh, I had a quick question. Sorry, Ryan.
no, please interrupt because I talk too much. So go.
Hi, Dennis. How are
Hi.
you?
Good. How are you?
I'm from Rocket Doctor. I come from your world of Medicaid, having worked with HealthNet and other advocacy organizations in California, like CAP and the California Association of Public Hospitals. Would love to hear a little bit more about your introductory comments on seeking providers. I think one of the interesting things I've been thinking about in terms of virtual care is having building partnerships with community-based organizations, as that's kind of a big element of CalAIM and how you all as managed care plans have to build alliances and partnerships with systems beyond providers to really understand the communities you're serving and really, focus on efforts around enhanced care management, community supports, and population health. Would be curious to know if that's the right approach in terms of building those relationships with CBOs and working with them to then have conversations with managed care plans to say, hey, we're working with systems in your area to deliver care to these populations you're serving. Would love to see how we can, form relationships and to work with you all.
Yeah, I mean, I think definitely a way to do it. I mean, I'm curious to hear more, like, what would you be selling to me as a managed care plan?
So
Well, I can
you're
suggest
putting me
that.
on. Okay, go ahead, Bill.
Yeah, you're welcome to take it if you like. But hey, Dennis, I'm Bill. My background's in emergency medicine, public health. I'm the owner and CEO of Rocket Doctor as well. But our primary focus is on emergency department diversion of low acuity Medicaid patients, primarily, and getting them comprehensive care outside the four walls of the hospital as an ER physician myself, particularly. And it was interesting as I was listening to you about telehealth. It's totally true. There are for sure lots of things where you need me in the ER, but one of the reasons for starting the company was there are so many things that can be managed effectively with the right technology and with the right program of matching the right provider to the right patient. So our model is quite different in that it's like a Shopify for providers where docs are actually independent and get to tell us their clinical preferences for managing care virtually, and then we match them to the right patient in that way, and integrate both the ability to order labs, imaging, book follow-ups, and have that kind of comprehensive care. And just as a final plug, we were recently accepted into the PATH program as a vendor for technical assistance. So that hopefully will make it easier for folks to work with us. But
So, like,
Yeah.
so I guess are you sort of, I guess, who are you marketing to? Are you marketing to the plans like, hey, like, put my phone number on there, so instead of going to the ED, people call me, and then I will connect you to one of my docs to get them started so they don't end up in the ED and get them, the care that they need. Is that what you're selling, or are you selling to the plans like, hey, connect me to your providers, and then I will help your providers make tele appointments available? Or like, so what are you pitching to me as the health plan?
Ashley, did you want to say something? You're
Go
welcome.
ahead, Bill.
Yeah, no, it's funny having both of us on the line. Feel free to add anything that I missed. But I mean,
Yeah. Go
I
ahead.
think the interesting thing here is that because we're both we're both a technology platform, and myself being a California physician, we've created a practice group as well. So what's really neat is we can actually do both, and that's what we've talked, had conversations for about a year or so with a bunch of different FQHCs and other folks about how we could, and CBOs. So like we work with the Housing Authority for the city of Los Angeles to help implement a program for folks in residential housing complexes where we can work with their members and then partner with FQs on the ground to sort of send patients when they do need in-person care. We've talked to FQs to say we can use our technology to allow your providers to better do virtual care, or if required, as you were just saying, we can plug in the docs that are on the platform that take Medicaid, and they're willing to take Medicaid because of the model that we've built and kind of the whole ethos of the company. So yeah, I think, I don't know, Ashley, do you want to add something on there?
Um, I I want to be mindful of everybody else's questions and time, and if this is something we can take up offline with you, Dennis, just because there's also elements around community health workers that are built into our system that allows for coordinated care of how we support members that align efforts with CalAIM, and that being a reimbursable service and social determinants of health. But I'm happy to circle back just to give folks, other folks on the call, opportunities to chat.
Yeah, I mean, this would be interesting, right? Because I mean, I think if you're selling me, hey, like, I can, instead of your nurse advice, in addition to your nurse advice line, like, instead of sending people to ED, they send it to us and we get them seen so they don't go to the ED interested, right? Like, because that's sort of, lots of pain points, right? One of the pain points is traditional pain points is people feeling like they don't have good access to care. They call their primary care office, they call their nurse advice line, someone's like, "Oh, I have chest pain." They're like, "Oh my God, you need to go to the emergency department immediately." And they didn't get the part like, "Oh, I just got hit by a baseball in the chest." It was like, "Oh yeah, you're not having a heart attack, duh." But like, they never get that far. It's like they hear chest pain, their head explodes, they send them to the emergency department. So like, I think it doesn't answer your original question, Ashley, because I think it's sort of like, I think if you're selling that, could, I don't necessarily need you to have the relationships with the CBOs or the clinics, right? In that case,
Yeah. I
right?
think what
Like,
we've seen though, working with like, for example, the housing authority for the city of Los Angeles is
uh-huh,
they're catering to these populations who, and in specific areas, for example, like Boyle Heights, predominantly Latino
sure,
population, where hey, maybe they have family members that are uninsured that now have access to healthcare and Medicaid by signing
uh-huh,
up, but will not. So how can they, how can they be in a supportive environment where they cannot have access to care? And that's where we could have a kiosk set up on the side of the
uh-huh,
housing space where people can,
uh-huh,
utilize our virtual care platform to get access to a doctor and have
uh-huh,
access to medical devices to use in
uh-huh,
the comfort of their own housing building, right? Instead of being like, okay, I'm scared to call this
uh-huh.
primary care doc or FQHC. But again, happy to talk offline. I
Yeah.
want to be mindful of people's time.
No, I think it's a good question. I'll just sort of give you my 2-second thoughts on that, right? Just, I think super valuable service, definitely the right thing to do for the person,
Yeah. Yeah.
right? But the question is, who's the right payer, right? I think that's sort of the question. And I think this is a good example of like, how, depending on who you're pitching, different things that stick out to each person, right? Because as a health plan, if they're afraid to sign up for Medi-Cal, right, they're inherently not my member. So like, even though I agree it's the right thing to do as a doc,
Yeah.
right, it doesn't make sense for me to pay for services for people who don't belong to me, right? So in that case, it's sort of
Mhm.
like it's sort of figuring out like, is it then going to be like, is your best customer, whether it be like the county of LA,
Mhm.
um, or is it like, or is it the hospital association? Because if these individuals are uninsured, they otherwise would go to the emergency
Well,
department.
that was just like
Yeah,
a
no,
small
totally,
example, but we can talk offline. I want to be sorry,
totally,
y'all.
no, totally. Happy to chat more offline. I mean, it sounds really interesting. And so could be, it sounds like there's some fun stuff there. So I'm interested in hearing more.
Uh, I do have another question. So, what's Central California's Alliance for Health's goals for the next 2024, 2025 in terms of like what are you guys trying to accomplish? You have a ton of things you're doing. So for you to be here right now talking with us, right, there's probably some sort of objective you're trying to achieve. So I'd love to hear more about what you're hoping for and looking for in terms of over the next
I
year or
mean,
so.
I think there's sort of different levels to that question, right? I think for Medicaid plans in
Give me the
California,
deepest level.
right? So I
Very
think the
intricate.
first level is like, for all the plans in California, we're having a lot of stuff thrown at us. So sort of like successfully implementing the whole barrage of programs, right? The second level of that is if you can make those programs actually come together in a way that makes sense, right? So it's not like, oh, I have a CHW benefit here, I've got a doula benefit here, I've got CalAIM here, whatever CalAIM here, enhanced care management here. Like, I think the right way to do this, which is often lost, is like, okay, I have a member, right? Or I have members. What are all their needs? And how do I make this all fit, right? As a cohesive package that is serving all the members' needs, right? I think that's a really hard thing to do. But if you're able to get there, then I think you're sort of doing a good job in terms of serving the member, right? Because it's sort of like, like make it make sense, right? If I told you you had to like call this number to like set up your internet, but then this number after you set up your internet to log in, you would shoot me, right? And I feel like that's often what Medicaid members have to go through, right? It's sort of everything's designed based on requirements and in silos. So I think, the underlying goal is obviously there's lots of goals, but I think in terms of the innovation side of things, it's really to create a system of care, not a silo of programs, if that makes sense. And then I think, beyond that, right? So that's like all the new stuff. Then there's the existing stuff, right? There's sort of the core challenges that healthcare nobody has figured out. That's, around basic access, right? Around access to specialty care, around avoiding ED visits, around avoiding hospitalizations, sort of, and a lot of the system of care is designed for that, right? Like the reason I think California is undergoing such focus on things like social determinants of health, on doulas, on CHWs, right? It's not because they're cool ideas, which they are, right? It's more so the goal, the ultimate goal is to improve health and hopefully decrease costs, right? Like that's just what health plans are trying to do, whether you're for profit or nonprofit. I mean, for profit, you may not be trying to improve health as much. You're trying to not save money, but either way, right? You're trying to save money and hopefully improve health, right? So I think it's a recognition that just, in an area where you do not have a shortage of providers, just getting another cardiologist is not going to help, right? It may just lead to more cardiac caths, but do patients actually need that? Or like if they have chest pain, do they really need to talk to a psychiatrist because they're just stressed out, not because they're having a heart attack, right? And the problem is they haven't had good access to mental health resources. So how do we make that happen, right? So I think it's the ultimate goal is, like I said, creating a system of care that works, that successfully integrates these programs, that has the outcome of improving health and reducing cost.
Now, when it comes to you were saying before, like if you have more cardiologists, then you end up just having more cardiology cases. In terms of like prior authorizations and those types of things, do you guys automate a lot of that prior authorization, or are you actively looking for any prior authorization automation solutions at all?
Oh, well, so prior authorization is an interesting space, right? Like there's no real point in because I control what has prior auth. I'm not sure having automation really is helpful, because if I'm going to automate it, then I might as well just get rid of it, right? There's no real point in requiring it if I'm going to just process it and approve everything, right? Like why do extra work for everybody? So from my perspective, right, like I know it's a hot topic, but for me, I don't really see the value, right? Because like nobody says I have to require prior authorization, and if it's a waste of everybody's time, why require it, right? That's not where I'm getting cost control, right? Like cost control is because the stuff that's the most expensive, I can't prior author anyway, right? Like EDs and hospitals, there's no prior auth for that for the most part. So it's sort of like if I really focus on controlling costs, right? It's really EDs, hospitals, long-term care, skilled nursing facilities, and building out creative programs to get people to the right place. Like some people have to be in the hospital, that's fine, but I don't want them staying an extra day if they don't have to be there.
Okay. No, that's actually really helpful because some of the private insurers and they've gotten recently in trouble for some of this, is using prior auth to reduce their costs. So it gives me a little bit more insight into your organization, that you guys aren't really looking at prior auth as a tool to reduce costs. It's just more about getting the right person to the right place at the right time.
Yeah.
If that's right. Okay.
I think probably overall, if you're treating people effectively, the first contact at the right time, and then moving on, like that's going to be your most effective cost savings, no matter what, right? Like appropriate treatment at the appropriate time.
Exactly.
Provider is going to save you more money no matter what other kinds of like magical constructs you come up with to try and like trim a bill.
Exactly. Because I mean, I think the hard part, right, is just like unless someone's blatantly committing fraud, like there's no real point in doing prior auth on things, right? Like if someone needs to go see a cardiologist, they need to go see a cardiologist. You know, I'm not going to spend $5 million to save $100, right? Like reviewing the ROI is just not there, right? Unless I'm
Do-
denying all cardiologist visits, then in which case I'm going to get shut down, right? So it's just sort of like
Yeah.
I think finding things like sure there are a couple things here and there that are high cost I'm going to review, but like if everyone's requesting the latest high cost X, then there's a different problem there, right? Usually the high cost stuff is also pretty relatively rare, especially because medications like Ozempic are carved out from us, right? Not my problem. Thank you, Medi-Cal RX. so, so like,
Yeah.
so like, the things, so like, for the things that I do are truly high cost and rare, I probably do want to look at those because I want to make sure it's appropriate and someone's not trying to scam the member, right? And then
Gotcha.
otherwise, I do retrospective over underutilization studies and go after providers who look like they're committing fraud, right? But that's sort of after the fact because that's a better use of my time.
Gotcha. And so I take it then, do you have like, because the Texas Gold Card law and a lot
Uh-huh.
of other insurers are starting to, well, United Health Group, they're getting their Gold Card program ramped up for like 2025. Have you guys already implemented that, or is there nothing really official like that you
I
guys
mean,
do with that?
and so good point. So just making sure everyone knows what gold carding is. Gold carding is saying, okay, if you generally have a certain percent of your prior auths authorized, then we don't review you, right? In my mind, that actually doesn't make any sense, right? Because like the stuff I want to review are very specific things, right? So if I'm requiring auths for everything, but the things that I don't automate are very few, right? You're always going to be above 95%. So like I'm also required no auth for most things and just look at the 5 things I think are a problem. And then, so in my mind, I don't think Gold Card is effective if there's a lot of things you're requiring authorizations for, potentially, although I still don't think the concept makes sense. Because it's just a numbers thing, right? And if you're basing purely on percentages, pretty much everyone's going to hit that threshold. So in my mind, like you should be smarter about what you require prior auth for and what you keep an eye on.
Yeah, private insurers are pretty much been requiring like prior auths for like everything, so that's why it starts to make a little bit more sense in terms of like what you guys are prioritizing versus the private insurers, and it's helpful to have.
And I don't know. I honestly can say never have I ever had anybody say to me, "Oh, my insurance company is so helpful." That has private insurance, so there's probably a problem there.
And one final question is the when you're working with providers or trying to recruit more providers into your network, like what are like the top 3 complaints or reasons why they decide not to accept Medicaid or not want to work with your organization or care for your patients or your members?
Well, I mean, I think the top reason is I say Merced and people are like ill, right? They don't want to they would rather live in San Francisco or Los Angeles. They don't want to live in the Central Valley. That's like the top 3 reasons right there.
Okay, so it's more location, but we can't really change that. But okay.
Yeah, that's the top thing, right? Like people want to live in the big cities. They don't want to live in rural areas.
Hmm.
Right? Unless
Do you think that extends beyond providers to nurses and medical assistants? And other kinds of-
all sorts of healthcare. I mean, I think, to that point, right? I think there are some efforts on workforce development, right, for those communities, for people who come from the community who want to stay in those communities to get them trained up, right? And I think that's probably the answer, right? All because I mean, we have trouble not just with doctors, right? We have problems with nurses, with mid levels, with MAs, with CHWs, you name it, right? We have problems with recruiting enough when enough individuals to work all in that service line.
Do you think people really don't want to be in more rural places, or do you think they feel like maybe they can't? Because I feel like it, in my own personal experience, like I tried to live in rural Texas and I
Mhm.
couldn't. There
Uh-huh.
was no way to make money and live. So it's like a little
Well,
bit of a chicken and egg situation to
uh-huh.
me, you know, like I would be there if the jobs were there and the jobs
Yeah.
would be there if the people were there. So like,
Yeah.
what are we doing here?
Well, I think for us, right, we have the jobs, right? We have the jobs and they actually pay pretty well. People just have like a knee-jerk reaction to the idea of living in Merced,
Ah,
right? And in my opinion, having spent a lot of time there recently, it's pretty nice and it's cheap relatively, right? I can get a nice house 350,000, right? That may be a lot, but like that's better than 1 million or 2 million. That's like a third to a sixth of the price, right? You can get like a nice house with a yard in a good neighborhood for pretty cheap, right?
how-
Relatively for California.
Jeez.
Do you feel that does the Alliance or other health plans, do they feel a priority to be working on workforce challenges?
I think we do, right? I think we are looking at, we just had before this, I just had a meeting on like, what are we doing to recruit providers, right? Kaiser is paying 250K signing bonus if you sign for 7 years, right? And we have that, but it's not being implemented in the same way. And my answer to my team was, look, you're paying 250K, but the organization using that to cover salary. As a doc, I don't really care where my money comes from as long as they're paying my salary. Well, if you're not giving me that as a signing bonus, I'm not signing with you, right? Pretty straightforward. So I think there's definitely a financial component. It's not the only component, right? But I think there's how do you get people to actually see it's, there's a UC there. There's a lot like Merced is growing. It's compared to some of the other areas. I was in Mariposa yesterday, right? I drove from Mariposa all the way up. I saw 0 traffic lights, 0 stores, 0 restaurants. So, Darby, to your point about livability, that's maybe there. They were telling me all of Mariposa County has 2 stoplights and they're both temporary. They've just been there for 15 years. There are 3 elevators in the entire county, right? And I've got 6,000 Medi-Cal members. And they have zero OBs in the county. They have 1 OB that used to go up to their hospital. Now anyone who has to deliver comes down to Merced, right? And I don't have enough OBs in Merced.
Yeah, that's a common problem, a lot of Colorado is extremely, extremely rural. I know there's at least 1 or 2 counties that have like 0 dentists, like none. Like there is not one dentist in an entire county in the
Yeah,
state, in the United States in 2024. Like what?
yeah,
So, which I think is really bizarre, but that's what happens. You're right. Like it's hard to live. I
yeah.
wanted to really quick, if I could just shift a little bit, since we have about 10 minutes left here. If I was just wondering, if I could ask you about health equity and your kind of thoughts on, because that is something that is really central to our particular challenges is, focusing on solutions that work for safety net patients and providers. And we were talking earlier in the day about, how do we know if we're being successful in like achieving better health equity and cultural competency and everything like that. So I was just curious if you had any kind of quickish top level, something you wanted to tell us about what you're thinking about or doing there.
Yeah. So, I mean, I could tell you a little bit about health equity is a huge goal for us, right? Like if we're talking how we're looking at what we're doing. And I think what I mean specifically for that, right? Once again, I have 5 counties. My 2 coastal counties, Monterey and Santa Cruz, are doing quite well in terms of metrics, right? However you dice it, number of providers, childhood vaccination rates, et cetera, right? Like Merced is way below the 50th percentile on a lot of measures, including childhood vaccination, including access to providers. So, I mean, there's lots of different ways to define equity, right? Like, I think, or lots of different areas rather that you need equity. For us, it's, DHCS is defining it as the set of, HEDIS MCAS metrics that they're using, which include vaccination rates, include, chlamydia screening, things along those lines. And so what we're doing is I'm going to all my Merced practices and saying, hey, what do you need to close the gap? Tell me what you need. Tell me what effect it's going to have. And I'm planning on paying for it. It's as simple as that, right? If they are going to hire 3 more providers and they're going to be locum so they can get all their vaccinations in, that's what we're going to do, right? Is that like total health equity? Definitely not, right? But is it starting with like DHCS's definition as they define? Yes, right? I think, a broader view of health equity would be really around, I think, the community supports, right? The work around housing, the work around food, around building infrastructure to address and make sure needs are addressed, social needs, right? And sort of social determinants of health, in my opinion, right, are sort of what are some of the longer term things. But in terms of as DHCS has defined equity, we're going out and we'll see what the providers have to say. I have my thoughts, but I'm not the one doing the work, so I'm just here to pay for it.
Fair enough.
Yeah.
Anyone
Any
else?
any other questions? Dennis, I'm curious, what is one thing that you want to share that nobody has asked so far?
What's one thing that I want to share? I mean,
I do have a question.
Go for it.
To save you.
I'll think about Janice's question. I'll let you know at the end of
Yeah, I know.
end of this question.
Okay,
So
sounds good.
how do startups generally approach your organization or insurers that work with Medicaid populations? Like what was the best startup you ever worked with in terms of like, oh yeah, we really want to engage with them, we really want to do it, and kind of what's the process of actually like getting a pilot with with your organization?
Yeah, I mean, I feel like we've worked with a couple, but I think it's sort of, in the spaces of stuff we were offering, right? Like community supports, I would say we worked with a couple of the food vendors who are sort of starting up in the space, right? A couple of them were CBOs and really sort of worked with them to build. Right now, Janet, the group you sent my way, right? We're going to contract with them to be ECM and doula providers, right? So I think, like I sort of said in the very beginning, I think most of the startups I've seen that we've worked with have sort of fit into the programs we're offering. Because like my perspective is like it never hurts to have a bigger network of providers, right? I'm never, as long as you're not a criminal, I'm not going to say no to you if you're a cardiologist, you want to be in my network. I can't guarantee you a volume of patients, right? But if you want to be a provider, I'm happy to contract you, right? It never hurts to have an extra person contracted, right? I don't think we've had many startups that have been a good fit in terms of like outside of fitting in as a provider in terms of like solving problems, right? Because I think some of the problems that are being solved are better directed at the providers, not at us, right? Like I have global problems, but a lot of them rely on providers doing things differently, right? And really sort of the providers are the ones to sell to, not me, right? Because if I'm telling them they have to do something, they're gonna give me the finger and walk away, right? It has to be what they want to do,
Yeah.
right? So because I already tell them plenty of things they have to do and they don't like any of it. So
Like pulling teeth, yeah.
yeah.
In terms of
So
like utilization management tools, have you ever been approached for about like utilization management tools or
yeah, and I basically said no because I'm just getting rid of aughts, right? I don't need any tools if I have no utilization management I'm doing. And the stuff I'm doing is requires clinical review, right? Concurrent review, placement, right? Like never have I ever met someone who does discharge planning well, right? And I'm not sure a tool is helpful. It's a general approach and just getting people not to be lazy. Right.
Gotcha.
It's about keeping my staff accountable. Like they know how to do this stuff. They just need to ask all the questions and actually do their freaking job. So, but if you have something that you think works, I'm open to it. I just haven't seen anything yet. Right.
Yeah.
That like because I have control over that, right? Like, sure, if I'm stuck in the framework, I have to authorize everything, then yes, I will need tools. But I'm not in that framework, right? I'm just like, if it's not bringing value, why are we doing extra paperwork?
Yeah. Makes sense. Yeah.
Yeah. And then I see James has
I
his hand.
see. Yeah, go ahead, James.
No, it's okay. I mean, my answer was kind of that, but I really want to hear the answer to Janet's question. I think that was Janet who asked that question earlier about
Mhm.
the one thing that we should all know. I don't want to get in the way of that.
I think we have just enough time to hear your final thought of what you all want us to know that we didn't think to ask you.
Yeah, I mean, I think it's the thing I've said, but I think it's sort of like it's really like understanding who's incentivized, right? Whose problem is it, right? There are a lot of problems out there, right? There are a lot of problems I'm interested in, but they're not necessarily my problem to solve, right? Even though it's related to me, right? Like it's sort of like the one, around the practices, right? Like the practices, do I want my practices to be more efficient? Yes. Do they want me to make them more efficient? Absolutely not. Right? They want to figure that out themselves. So if you're trying to sell me that, I would love to do it. I think it's valuable, but my practices aren't going to listen to me. Right? You should just be selling to them. So I think it's really that like thinking through. And I mean, I think, happy to bounce ideas, happy to sort of give you my perspective on it. But I think it's just asking, right? If you get turned down, like, is this your problem, or is there someone else that is responsible that I should be talking to instead? Right? Because it's not necessarily it's a bad idea. It just may be the wrong person. It's like that's not what it's not my financial responsibility. In that case, I mean indirectly it is, but not direct. Not operationally not mine. So like I think it's not always about just whose financial responsibility it is. It's also like whose operational responsibility it is.
Yeah. I think that's a really good thought and an important point and good place to leave it. I mean, that's kind of like a general sales, all sales, right? Personal, professional, know what you're selling and who your customer is and how do you both win? What do they want and how do you give it to them? And if they don't want what you have, maybe you should find somebody else who does, is how I would, very layman's
Yeah, totally. It's not necessarily what you're selling is bad, right? It's just
No, maybe it's the wrong place, wrong time. Maybe you didn't describe it in a way that was the key word they needed, but whatever.
Yeah.
Yeah. Awesome.
Well, we are reaching time. Dennis, thank you. Thank you as usual. Thank you so much for joining in. I see that Dennis has dropped his email in the chat. So if any of you would like to connect with Dennis, feel free to reach out. Other than that, thank you all so much for, jumping in at 3. And then, I know it's a long day today. And so I think y'all made it. So I hope that today's session was really fantastic. Thank you all so much for joining in. From the CHCF end, feel free to reach out if you do have any general questions about the fund. Other than that, I'm going to kick it over to Darby. Before I kick it over to Darby, please give a round of applause to Dennis. Send all of your emojis and all your claps. And then I will kick it back to Darby to share any Prime Health updates. And yeah, thank you all so much.